Hi, everyone. I want to thank the organizers of the COVID-19 Clinical Management Workshop for the opportunity to talk to you today. I will be covering a topic that is both intimately related to the SARS-CoV-2 pandemic while also being broader in some ways. And that is talking about the importance of vaccination in COVID-19 infection on diagnostics, as well as the impact of other respiratory viruses on diagnostic test performance and the implications of that for both patient care and public health. Here are my disclosures. The one relevant to this talk is the first one. I'm the section editor for the diagnostics section of the Infectious Disease Society of America's COVID-19 Real-Time Learning Network. This is a CDC-supported project that is not affiliated with any commercial entity. My objectives today are threefold. The first is to provide an overview of factors that critically impact the performance of diagnostics in respiratory virus infection. The second is to discuss how the pandemic has resulted in changes in influenza epidemiology. And finally, I want to highlight potential approaches to diagnosis for the upcoming season where more than one virus may be circulating. So let's begin with factors affecting test performance. So I want to begin by recapping the SARS-CoV-2 testing paradigm as it fundamentally differs from what existed prior to the pandemic. The characteristic of asymptomatic or presymptomatic transmission is not unique to SARS-CoV-2, but the imperative to stop transmission highlighted that existing diagnostic and screening strategies inadequately accounted for this property of the virus. A number of modeling and small epidemiologic studies now estimate somewhere between 40 to 80% of infections occur from an index case who did not have symptoms at the time of testing. And this despite the fact that asymptomatic people are less likely aerosolizing far less virus than those who are coughing or have other signs of congestion. So what sets the SARS-CoV-2 testing paradigm apart from traditional diagnostics for pneumonia, whether they be bacteria or viruses, is the fact that test results are tied not only to the patient's status, but also to the public's health. And it is for this reason, and only this reason, that we perform COVID tests in people with no symptoms, as shown in the table. Looking at it from a slightly different viewpoint, there are two use cases for SARS-CoV-2 diagnostics. The first is for active case detection in patients with high pretest probability, which is generally defined as people who are showing symptoms of infection or are close contacts of a known case. And here the test results will be used for clinical management of the patient. The second use case is for screening in people with low pretest probability, in other words, asymptomatic, and the results of testing will be used for infection control and public health purposes. So it is self-evident that a diagnostic assay sensitivity depends on how much of the target analyte is present in a sample, but what has been underappreciated until now is how factors like virus epidemiology and immunology play a key role in this. So what I'm showing here is a simplified pathway by which I envision upstream effects are propagated down to impact the probability of virus detection from a single patient's molecular or antigen test. This most proximal and tangible manifestation of this cascade is how much virus is present on a sampling swab, whether it be nasopharyngeal or taken from another site in the upper respiratory tract. So starting on the right and moving leftwards, the amount of virus estimated by the amount of viral nucleic acid is most directly related to the amount of virus that is present at the body site of sampling. This, in turn, is impacted by four domains of factors that include the degree of host immunity present, the kinetics of viral replication, where in the infectious course the individual is at the time of sampling, and the quality of the collection. I have connected host immunity and replication kinetics together as they interact with each other. The higher the concentration of neutralizing antibodies at the site of inoculation, the lower the ability of the virus to replicate. However, differences in the behavior of variants can also affect how much virus is made, as well as the kinetics of replication. The time point at which a sample is collected impacts how much virus is present in a host, as we know from studies of natural infection that sampling between days 3 to 7 post-infection is most likely to result in higher viral loads compared to those tested days 0 to 3 or after day 7. At a population level, this is dependent on the rate at which new cases are accruing in the community. And this is largely dependent on human behavior, which is in part driven by weather, rates of vaccination, economics, children's education needs, and a myriad of other variables. I will discuss the boxes highlighted in red in a bit more detail on the subsequent slides. We now have a year's worth of data showing the impact of vaccination on viral loads, which, as I just showed, is a critical factor determining test performance. This is a figure from a study performed in Israel showing viral loads in breakthrough infection in people following their first dose of the Pfizer mRNA vaccine. And you can see that as the SARS-CoV-2 specific protective immune response gradually develops over the first 2 weeks post-vaccination, the mean CT value in positive tests increased, corresponding to lower amounts of virus present in samples. The ranges around each estimate greatly widened as the number of infections precipitously dropped. This was one of the early studies to suggest that vaccination not only improves patient-level outcomes, but also may contribute to decreased population-level transmission. However, the previous study was performed when the predominating circulating lineage was the alpha variant, formerly called B.1.1.7. The interaction between protective immunity from vaccination and viral evolution drastically changed with the rise of the current dominance of the Delta variant. So I'm showing on the right a figure from an outbreak investigation performed by the CDC over the summer of 2021 in Barnstable County, Massachusetts, just a few weeks after the July 4th Independence Day holiday. They defined a large cluster of positive cases in vaccinated and unvaccinated hosts and showed that the distributions of CT values between the groups were overlapping. This was one of the most important early studies showing how viral evolution can quickly get ahead of the immune response in terms of replication. The impact on transmission has been moderate, meaning that people infected with the Delta variant are more likely to transmit compared to infection from Alpha, but it is still less likely compared to unvaccinated individuals. And while the population benefit from vaccination may have waned, there's still plenty of data to suggest that those vaccinated are still well protected from severe disease, indicating that the patient-level benefit remains strong. Finally, a number of recent studies suggest that vaccination results in a more rapid clearance of the virus, which may be the pathway by which they result in decreased transmission relative to infection in fully susceptible hosts. So I was showing one such study performed in a cohort of 84 vaccinated and 130 unvaccinated individuals in Singapore over a time period when the Delta variant was the dominant lineage. And the x-axis represents days since the individual's infection began, and the y-axis is the CT value. The scatter plot shows a separation in the mean viral load starting around day 6 after infection, which reflects the recruitment and expansion of virus-specific B cells and T cells. This data, along with a cross-sectional study, highlights that while viral loads are similar in vaccinated versus unvaccinated people, they decay faster in an immunized host. So the bottom lines for these observations I showed here, as I've said, diagnostic sensitivity is directly related to how much of the target analyte is present. In this case, that's SARS-CoV-2 nucleic acid in the swab. And I anticipate that the utility of symptomatic testing protocols will remain mostly unchanged as the peak viral loads for vaccinated individuals with the Delta variant are similar to those who are unvaccinated. Most of this relies on the assumption that those with symptoms are earlier in their illness curves, on average between symptomatic versus asymptomatic people. However, I believe that the effectiveness of asymptomatic screening programs to detect recent cases will be, or already is, abrogated. While this may not be a problem for the majority of people with protection, it does make it much more challenging to identify and perform contact tracing. So now I move on to the interactions of SARS-CoV-2 with influenza from the perspective of diagnostic testing. So as we all recall, there was a lot of concern heading into the fall 2020 influenza season that we could be faced with having to handle and distinguish infection from COVID and influenza at the same time. These fears fell by the wayside as it became clear first in the Southern Hemisphere and then in the Northern Hemisphere that flu transmission basically came to a complete halt. On the left, I showed data from the United States showing an early abrogation of the seasonal influenza epidemic shortly after the declaration of the COVID-19 national emergency and initiation of lockdowns across the country. Transmission at comparable times from prior flu seasons are shown in the dotted and dashed lines. On the right is similar data from New Zealand using multiple different surveillance systems. The red line at the bottom represents influenza cases shortly after lockdown in comparison to prior years in black and blue lines. Transmission, of course, is highest during June, July, and August in New Zealand, as this is their winter. So far in 2021, the trend of decreased influenza transmission continues, but as I will discuss, it is far too early to write off influenza this year. This is just a panel from a perspective piece suggesting that the aggregation of influenza transmission in the past year may have been so severe that it may have even led to the extinction of an entire clade of the virus. In this case, the influenza B Yamagata lineage. It is thought that this may be related to the fact that the reproductive number for this clade is less than that of the A lineages and that of B Victoria, but also because it has not shown any mutational drift in the hemagglutinin protein for the past 5 years, which means that the vaccine has been highly efficacious against it. The interactions between SARS-CoV-2 and influenza are complex and not completely understood, but a big factor would likely be the impact of non-pharmacologic interventions that include distancing, the segregation of children from adults, as well as decreased air travel, which is mostly limited to adults. The impact of seasonal vaccines is also important, as we know. And then, as I mentioned, there are probably lineage-specific factors for different influenza clades that lead to decreased transmission or differential impact based on in the setting of a non-pharmacologic intervention. Anecdotally, here in Boston, our hospital system has seen very little flu circulation to date, but there are reports of activity picking up in pediatric populations, which is usually a harbinger for spread in adults a few weeks later. So I do expect our numbers to begin rising after the Thanksgiving holiday. And so 2021 may actually differ from 2020 because viruses, while albeit they're present in low numbers, they are still circulating. We are working with very little data in terms of the degree to which it is mutated away from our protective immunity. We cannot rely on herd immunity from the past year, and our surveillance systems may not have captured significant mutations that may have led to decreased vaccine efficacy. So an overarching lesson that we learned from the SARS-CoV-2 pandemic is the critical role of diagnostics in not only promoting clinical care, but also for public health. The two realms are really inseparable when the goal is to stop respiratory virus transmission. So luckily, in the past 5 to 10 years, there have been a plethora of multiplex PCRs as well as syndromic panels that have bundled detection of many of the most common viral and bacterial pathogens into a single test, and almost all of them have added SARS-CoV-2 to their existing panels in the past 12 months. This is theoretically one way to sort out respiratory infection for this upcoming virus transmission season, but it's not as straightforward as it may sound. First off, there are operational challenges around the use of nasopharyngeal swabs that we all learned about in the prior season. Data is currently non-existent on whether anterior nasal swabs will be suitable for capturing viruses like RSV or influenza. Therefore, we are required to use MP swabs, which limit the ability to perform serial testing due to patient discomfort, particularly for children. Secondly, traditional testing strategies have focused on symptomatic individuals to reduce the possibility of picking up asymptomatic colonization. If multiplex panels were suddenly to be deployed in large-scale screening settings, it is entirely within the realm of possibility that we would pick up the presence of many viruses and bacteria that we were previously unaware of. Some of these may be important and worth intervening upon, such as influenza, others less so, for instance, rhinovirus. But until there are guidelines for how to manage positive tests in asymptomatic individuals, particularly those with immunocompromise, testing is really best reserved for people with symptoms only. Furthermore, issues of quarantine and use of isolation rooms in the hospital can have severe negative consequences, particularly as our healthcare systems have very little reserve capacity for overflow. Therefore, it's imperative that these measures be deployed only as needed. And not shown here is also the issue of co-infection, which is estimated to be around 8% for SARS-CoV-2 and influenza, the clinical significance of which remains poorly defined. On a positive note, I think our in-depth investigations into the virology and epidemiology of SARS-CoV-2 can be applied to other respiratory viruses. In particular, I am referring to gaining a better understanding of the length and nature of asymptomatic transmission and the impact of vaccination for viruses like RSV or influenza or adenovirus. And this may actually lead to changes in our testing protocols and hopefully a reduction in mortality and morbidity from these commonly encountered pathogens. Syndromic panels may be helpful, but thought needs to go into the deployment, and results require calibrated pre-test probabilities to the greatest extent possible in order to make decisions that balance patient well-being with public health. So I want to thank you all for listening, and I'm happy to take questions in the discussion section.